To our USMLE prep question answer series. Today we have our wonderful Dr. Roland Singh. Hello, how are you doing today?
Doing well. Thank you for having me back.
Of course. Dr. Roland is one of our USMLE counselors that just matched into residency, so we're super proud of him, and that's great. And then we also have with us today Dr. Lumical. And Dr. Lumical, here, try talking, because then I'll find you on the screen.
Yeah.
But Dr. Lumical is our provost here at St. James School of Medicine. So we're so great to have you. And I know that you studied cardiology and you're a cardiologist.
Yes.
So this week's question is going to, touch on all of those fun.
That's why I tell them to be careful.
Yeah, exactly. Okay, so Dr. Roland, would you like to take it away?
Sure, thank you. So today we're talking about the 45-year-old female post-motor vehicle accident. Once again, special guest, Dr. Lumical, thank you so much for your time. We appreciate you being here.
Welcome.
Ms. Megan, thank you for putting up with my antics, as always.
I look forward to the exchange with the students here.
Absolutely.
Yeah.
So today's agenda, we're going to go over the question of the week. We're going to go over the wrong answers. And this week, we're trying something a little bit different. I'm going to have a lot more images, a lot more pictures. Why? Because the picture's worth
1,000 words.
And then Dr. Lumical is kind of to talk about CHF management. So we are definitely looking forward to that. So without further ado, here's the question for those of you who have not done it before. Let's do it together, right? So first thing you want to do, read the question. So which of the following is the most likely cause of this patient's deterioration? Right? That's the question. Why is she deteriorated? So what do we have? We have a 45-year-old female who comes to ER with significant blunt chest and head trauma after being involved in a motor vehicle accident. Shortly after she arrives, her blood pressure drops suddenly and she begins experiencing respiratory distress. On physical exam, the patient is tachycardic and tachypneic. Her lungs are clear, right? Lungs are clear to auscultation and with vesicular breath sounds heard bilaterally. So lungs are clear. Cool. She also has a jugular venous distension and her systolic blood pressure falls 15 millimeters of mercury with inspiration. So the three big points right there. So going back, which of the following is the most likely cause of this patient's deterioration? So for those of you who have not had a chance to do this before, please type in your answers. We do not judge. Megan might be judging, but we don't judge. So please type in your answer and why you think it is so.
I'm not judging anybody either. I think you all know a lot more science than I do. I mean, I'm just the social media person here to help out and make sure everything goes right. So I'm, trying to hone in on my small anatomy that I do know. But
should be a doctor before we know.
Yeah, they're gonna teach me.
Okay. So once again, please type in, for those of you who have not tried to answer this question live before, please type in what you think it is, A through E. We'll give, 10 seconds on the clock?
Yeah, so...
So they'll be typing their answers?
Yes, for those who have not done before.
How many are out there?
So currently we have 10 people watching right now.
And we love each and every one of you.
Yes, you're doing great. So again, if you want to comment in the comment section, then we'll kind of go through all of those answers and break down, which one works, which one doesn't, and why. Okay.
We just scared 3 of them away. So here's the X-ray that we gave through social media, right?
Mm-hmm.
So without giving too much away, I want you to focus on this area right here. Right here. Okay.
And what are they focusing on over there?
So
why is that?
You're looking at the gross enlargement of the heart, almost like globus pallidus, right? So the very enlarged heart.
Mm-hmm.
So once again, what do we know? We know it's a female who came in from a post-motor vehicle accident. We know she has rapid heartbeat, rapid breathing, but her lungs are clear, which hinting about this right here.
Okay.
So basically what happened? So a patient developed a cardiac tamponade secondary to a pericardial effusion. So for those of you who remember your cardio, let's go through it together, at least the pathophysiology together. So what is a cardiac tamponade? Well, let's go back to a pericardial effusion. So a pericardial effusion means that you have fluid buildup in the pericardial space. More specifically, as the fluid is building up within the visceral and parietal layers of the pericardium, it's causing increased pressure, right here, increased pressure in the pericardial space. Now, the increased pressure pushes on all sides of the heart, but because the right side of the right ventricle is thinner, you have more pressure compressing that area of the right side of the heart.
Did they answer what the choices?
No one answered so far.
Yeah,
No?
I think you should have let them answer which one.
Yes. So Megan actually gave them the question last week. So
Yes.
they had a full
Oh,
week to
they-
answer.
Did
Yeah.
they vote for their? Did they correctly choose?
Well, so we had a good mix of answers. A lot of people this last week had selected E as their selection, which is cardiac tamponade.
So
Yeah.
the majority got the question correct.
But ask them, what were the clues? Can you chat with them? What were the clues that made them choose cardiac tamponade?
So if you guys want to respond in the chat section with your different answers of why you think it's cardiac tamponade, that would be awesome. And then Roland's just going to run through kind of his thought process on the matter.
Give me 3 reasons for the students. I want them to give me 3 reasons why they chose cardiac tamponade based on the history that Roland gave you. What are the 3 important reasons? Anybody? Don't be shy. Start typing in.
Can people watching from like Instagram, LinkedIn, whatever, if they type, do you see it as well?
Yes, so we are currently streaming live on Facebook and LinkedIn, or Facebook and YouTube. So when they respond, it will come up in the chat.
Oh.
Yes.
Did they hear me?
Yes, they heard you.
I think they might be shy.
They may be shy today.
Type in 3 reasons why you chose cardiac tamponade based on the history.
So no pressure. We'll give it maybe like a minute and then we'll continue because we don't want to put you on the spot.
Yeah. There's a lot of great discussions on Instagram of, people commenting with each other and things like that. So hopefully they show.
And going into that, I think Megan's exactly right. Even if you get the question wrong, it's all part of the learning process, right? We much rather you get the question wrong now than on the MBME or on the step, or heaven forbid when you're taking care of this patient on the floor. So make your mistakes now, ask the questions. We have the wonderful Dr. Lumacow, practicing cardiologist. So if you have any questions for this case, please type it out. Okay. But shall we continue? I think they're being shy, Dr. Lumacow. Okay. So going back to the pathophysiology, what do we know? We have the compression of the right ventricle, right, with a thinner wall. And so it actually shifts towards the left ventricle chamber. So I'm sure you remember the left ventricle is a very thick area that's actually able to push all the blood into the aorta. Well, the thing is that if you have the compression of the right side of the heart, you have a shift towards the left ventricle. But at the same time, you have a decrease of the ventricular diastolic filling, right? You have less physical area. Because you have a decrease of the ventricular diastolic filling, you have a decrease in stroke volume and decreased in cardiac output. Okay. So, like we mentioned, a picture's worth 1,000 words. Here is what's happening when you have a tamponade. You have an increased pressure from the blood pushing on the right side of the heart, pushing on the left side of the heart. So the amount of blood going into the afterlobe actually decreases, right? You have less blood going into the aorta. If you're paying attention, our beloved Megan actually gave the info away during the Instagram posting under one of her hashtags. I think she gave it away.
You always have to look at the hashtags. You never know what you may find.
Absolutely. So great call from Megan. So let's make the question a little bit harder, right? So new trivia question. So what do we have from last time? So those of you who actually, oh, fantastic, well done. So she has JVD. Her systolic blood pressure falls 15 millimeters of mercury, also called pulsus paradoxus. So very good. What if I give you one more clue? What if her heart sounds are actually muffled? Right? So JVD, hypotension, muffled heart sounds. Here's my trivia question to all of you. What is this called? A very specific nomenclature for this constellation of 3 things. Hypotension, JVD, elevated JVD, and muffled heart sounds. 15 seconds on the clock.
Yeah. Do you have any ideas of what it could be?
Well, what do you call that phenomenon where the blood pressure drops off with deep inspiration? Anybody?
Starts with a P.
Pulmonary.
No.
No?
Good guess, though.
You know, I'm trying.
PUL? SBS? So Dr. Lumenkow was talking about pulsus paradoxus, right?
Yeah.
So
Okay.
a greater than 10 millimeters, I believe, 10 millimeters. So normal drop in blood pressure is 10. Oh, fantastic. Well done. So normally it's 10 millimeters of mercury drop. If you get above 15, I believe it's pulsus paradoxus.
Okay.
But going back to my trivia question, we have muffled heart sounds, hypotension, and a JVD. What is this?
Yeah.
This is
But you have to tie up the pulsus paradoxus with the diagram you had with the shift of the septum to the left.
yes.
Therefore, if the septum shift to the left, notice that the left ventricular volume there, comparing the healthy one to the tamponade, notice that the volume is larger in the healthy one and it's reduced when there is a shift. Therefore, the output into the outflow, the aorta and eventually to the peripheral vein would go down. And that's why even on the bedside, you can get a hint in terms of cardiac tamponade by feeling the pulse, asking the patient to inspire, and the pulse disappears if it's even there. So that's a big lesson. It's pulsus paradoxus, shift of the septum to the left, reducing the volume on the left side. Okay.
Absolutely.
Very interesting.
So going back, this is called Next Triad, right? Next Triad. So the constellation of three symptoms. What do we have? We have the muffled heart sounds. We have the distended neck veins, the JVD, and hypotension. So I know a lot of students use a sketchy, which I think is a great way to kind of memorize, but they kind of memorize the image and not quite what's going on. So let's take a step back. I don't want you to memorize, I want you to understand. So let's take this image as a whole. What is going on is that you have blood in the pericardial space. So if you think about, if you want to listen with a stethoscope, it's muffled because it's surrounded by blood. So boom, muffled heart sounds. Like Dr. Lumenkow mentioned, you have decrease of blood flow going to the aorta, right? Decrease of blood flow, hypotension, decrease of blood flow. And on the third stage, what about the backup of the flow of the right side? So you have all this blood surrounding the heart, right? All this blood surrounding the heart. It's also going backwards as well. So going up the superior vena cava, causing a distended neck vein or JVD. So you don't have to memorize anything. Just think, what is going on? Where's the blood not going to? Where's the blood backing up into as well? So that's triad.
Interesting.
So let's talk about the wrong answers. So wrong answer number 1 is the pneumothorax, or air in the pleural space. So I took the liberty of giving you 3 specific cases: closed pneumothorax, open pneumothorax, and a tension pneumothorax. So what are the differences between them? It's more the basis of air. Where's air going and where's it not going? So in the open pneumothorax, if you look at the air out, you have air both going in and out. So an open pneumothorax. In a closed pneumothorax, there's no air going in or out. It's actually going from the lung into the pleural space, into the air in the pleural space. And these are common cause like blebbing secondary to Marfan syndrome. You can have secondary COPD, malignancy, cystic fibrosis. These are all causing internal blebbing, so closed pneumothorax. Right? We talked about open, we talked about closed. Here's a quick picture of a bleb right here. So if you think if it ruptures, then you have a closed pneumothorax. There's no opening to outside space. But what about a tension pneumothorax, right? In a tension pneumothorax, you have an opening, but it's only going one way. Because I'm sure you remember the pleural space is negative, the negative intrapleural space. So when you have an opening, air is coming in, right? But it cannot escape. So all of the mediastinum is being shifted. Now, once again, mediastinal shifting. So if you look at the heart, and the left side of the lung is all being shifted away from the tension pneumothorax. In this case, because the X-ray does not give you that information, at the same time, you have bilateral clear lung sounds. They are hinting that she does not have a tension pneumothorax. So tension pneumothorax is the incorrect answer. So here's another picture of a tension pneumothorax going the opposite way. If you look at the mediastinum, it's being shifted towards the right. And once again, here are all the signs and symptoms.
Okay.
She has diminished breath sounds in a tension pneumothorax. Why? Because there's no air exchange here. And once again, in our case, her lungs are clear to auscultation with vesicular breath sounds heard bilaterally. So she does not have a tension pneumothorax.
Okay.
How about the next wrong answer choice? And here we're talking about an epidural hematoma, right? Well, the epidural hematoma is also the wrong answer because the X-ray does not give you an epidural hematoma, so that's definitely wrong. So what's an epidural hematoma? It's a rupture of the middle meningeal artery. More specifically, most common location is trauma to the arteriole. So if you feel the side of your head, that slight depression, that's a very thin area of bone. So it's very common to get some trauma to that area, causing a rupture to the middle meningeal artery, causing blood in the epidural space, which actually shifts everything away from it. Right? So bleeding in the epidural area, causing hematoma, causing a midline shift towards the right. So once again, epidural hematoma is the incorrect answer.
And if you have any questions that you want to ask in the comment section or clarity and anything that we can kind of touch on a little bit more, please feel free to respond in the comment section below, and we'll be happy to, address some of those.
Absolutely. So here's another picture of, here's a picture of a hemothorax, right? So hemothorax, you actually have bleeding into the thoracic cavity. Right? So let's do a trivia question. What organ do you think is this right here? Trivia question here, and what do you think this is? So going back to Anatomy 101, what organ am I thinking of? What organ could this be right here? Causing bleeding, right, into the thorax. 10 seconds on the clock.
Bleeding into the thorax.
So what organ is right here on the right side of right? Okay, 5 more seconds on the clock. So I'm thinking this might be a liver laceration. Would you agree with that, Lumika? So looking at this area right here, the reason why I'm thinking liver and not lung is the fact that if it was a lung issue, it might cause a tension pneumothorax, might be collapsing of the lung. In this case, I would venture to guess it is the liver. The kidneys are here, these right here. Okay. So it's actually above that area. Okay. So what happens in the hemothorax? Well, in the hemothorax, you have a lot of blood in the thoracic cavity. Is very similar to having increased amount of pressure pushing away. So similar to a tension pneumothorax, instead of air, we actually have blood pushing everything away. So we might have dyspnea, diminished breath sounds, you might have a dullness on percussion. Because if you think of all the fluid in the area, when you tap on it, it sounds very dull. Right? One thing to keep in mind, if the patient did have hemothorax, that means she's having a lot of bleeding into the area. Previously, we talked about JVD, right? So JVD means that she has increased blood pressure going back up. In this case, because she has a lot of bleeding, if anything, the JVD might be diminished or flat because all the blood is pooling in the thoracic cavity. So that's why a hemothorax is incorrect. Okay. What about aortic rupture? Right? So aortic rupture, if you remember your anatomy, the most common location where the aorta can actually be ruptured is distal to the exit of the left subclavian artery. So it goes brachiocephalic, left carotid, and then left subclavian, but they're all anchored. Right? The aorta, once you go distal to the left subclavian, actually is free floating. So if you have the rapid deceleration, you can actually get a rupture in that area. So it depends on the patient. But I would argue the fact that if she had a major MVA, a severe crash, if she had a massive tear, she might go into hemorrhagic shock. So tachycardia, hypotension, bleeding into the thoracic cavity, maybe a hemothorax, like we mentioned before. Because she has clear lung sounds, because they're not talking about severe hypotension, I would argue that this is incorrect. So aortic rupture is incorrect. So with that comes to the end of the question and answer. I'm sorry, the going over the question. I'd like to go give the presentation to Dr. Lumical, who will be talking about management of heart failure. So Dr. Lumical, the floor is yours.
Yeah, well, some of it did go through, but I think we'll just go to the last slide that I gave you. Okay. No,
The last one.
That he gave me.
Yeah, the last one. Just there.
Okay.
Yeah. Okay. Just briefly, in terms of congestive heart failure, I'm sure you're all familiar with the modes of treatment with congestive heart failure. I'm sure you went through all this already with your lectures. So the modes of treatment are what? Anybody? You can see the answers there.
Just
There's some evidence what the use of the important thing in congestive heart failure is to realize that the congestive heart failure comes about because of the activation of our neurohumoral system, right?
Mm-hmm.
So it activates your RAAS system. Okay, so in terms of your ACE inhibitors, those are the first ones that were used, right? There were so many studies with SOLD, Consensus, yeah, and ARI and SAVE. These are very important things. So the activation of the RAAA system. The next is the activation of your sympathetic system, right? The usual feature in congestive heart failure is an outpouring of catecholamines, right? If you have a patient in congestive heart failure untreated and you measure the norepinephrine levels, it will be very, very high. Okay. Activation of the RAA system also induces the activation of aldosterone with increase in sodium retention and water retention, so you have a congested state. So in terms of the RAAA system, then the systems that are involved are ACE inhibitors, your angiotensin receptor blocker, and in terms of sympathetic system, you use your beta blockers, right? Yeah. And in terms of the aldosterone secretion, you use your aldosterone inhibiting agents, your mineralocorticoid antagonist, we call. So these are the forms of the basis for the treatment of congestive heart failure. Recently, we have the so-called ARNI. Ar- Anybody knows what ARNI stands for? Angiotensin receptor neprilysin inhibitor, right? And it has been shown that comparing it to just ACE inhibitors with a study called Comparing ARNI and ACE inhibitors, there is a 20% more improvement with the use of ARNI. So this is now the form of treatment that is advertised as a form of therapy that's more effective than ACE inhibitors or ARBs. It's not in big clinical use yet because it's new. People are reluctant to use it. And perhaps more important, it's expensive. Okay. So the other new thing in terms of congestive heart failure is the use of SGLT2 inhibitors. Okay. Uh, there are two studies that we can go back on that. Can we get it? There. The Emperor and the. Can you read that? Yeah.
Galactic.
Yeah. So those SGLT2 inhibitors are very, very important. We don't know exactly how they work, but the important thing is they work in congestive heart failure, reducing hospitalization by 30%. This is started as an interesting thing because these are used for diabetes, of course. And they found out that the diabetics who were in congestive heart failure, hospitalization was reduced by 20 to 30%. So they did a study. How about mixing them up? Will it still work even if they're not diabetic? Sure enough, it's the same, 20 to 30% reduction. Okay. So in terms of congestive heart failure, to be brief then, the drugs that we use are ACE inhibitors and ARB. Better still with ARNI, sympathetic blocking agents with beta blockers. So what are the beta blockers that we use? Okay, it's a beta 1 receptors that are the effective one. Okay, and we have bisoprolol and metoprolol. Carvedilol, which is very interesting because it blocks beta 1, beta 2, beta 3. And it was compared with metoprolol tartrate, unfortunately, which is the short acting. And it was shown to be more effective than metoprolol. So, beta blocker, ACE inhibitors, neprilysin, yeah, SGLT2 inhibitors, and aldosterone antagonists. These are our mainstays in the treatment. But we have something new that has developed. One is, as you can see there on the right corner, is ivabradine. Okay, this is a very interesting agent because it slows down the heart rate by selectively acting on the sinoatrial node by blocking the so-called funny channel. So for patients who are given beta blocker, but you still have tachycardia, heart rate above 70, which defeats the purpose of treating the congestive heart failure, you can use ivabradine, but it's still it's not the consensus is not there yet. But I anticipate that when the task force for new new guidelines for the treatment of congestive heart failure, this will probably be used. At the moment, it's suggested to be just a 2A recommendation which you may use. We have also another study, the so-called galactic study. Galactic study, okay, which is the use of Very sick what? Very sick what is very interesting because it stimulates a GMP. GMP ultimately results in the generation of nitrates with its beneficial effects with vasodilatation and all that. Okay. The last one that I want to talk about is the left upper corner.
This over here.
Yeah.
Paradigm.
The
Paradigm
although
HF.
I was not looking at when I talk I couldn't print my own. It's the left upper corner that it's the GMC stimulation with versiquat, and then the one on the bottom there is the myocyte activator, which is an interesting concept. It's called the actinomycin thing. If you look back at your previous treatment of congestive heart failure with the use of inotropic agents, they were all bad because while they improved contractility, myocardial contractility, they were all associated with increasing mortality. But with this new development, myosin, so it's overactive mecarbil is the drug that's used. So this is the one on the bottom of the thing. Yeah.
Okay.
So at the present time then, the forms of treatment for congestive heart failure would be ACE inhibitors. It's going to be supplanted in IRBs, and it's going to be supplanted by ARNI, the use of beta blockers, the use of aldosterone blocking agent, and lately the SGLT2. So ibuprofen, I talked about earlier, the myosin activator, and the GMC activator. The one on the right upper corner is use of nitrates and hydralazine, which has been effective for the Black population. So the use of that is really intended for the Black population. Okay. Now I have a question for the students. We said that do you have the thing on the beta blockers? Yeah.
Thing in the beta blockers. This over here.
Well, unfortunately, it was cut off. But the use of beta blockers, bisoprolol, metoprolol, and carvedilol, is effective in 25 to 35% of patients with congestive heart failure. So it's a very, very potent and effective drug to use in congestive heart failure. My question for the students now is this. If you are doing a physiology test and you want to measure cardiac contractility, and if you add a beta blocker to the bath and measure contractility, what will happen to contractility if you add beta blockers? Increase or decrease? Give me your answer. Type it in. Did you hear the question? If you add a beta blocker to a bath and measure contractility, what will contractility be? Will it be increased or decreased? Go on, don't be shy. Decrease.
Oh, yeah, we have a couple of people
Decrease.
saying decrease.
Correct.
Yeah.
Correct, decrease. Now with a correct answer like that, why do we use it then in congestive heart failure where the EF is already reduced? How come we have benefit? Answer. Why?
So can you restate your question one more time?
Yeah. Type your answers.
So the question was, if we're giving the patient beta blocker because of decreased ejection fraction, why on earth would we do so? So what's the reasoning of giving a beta blocker? So what's the physiology of the pathophys when you give a person a beta blocker?
So we're having a couple people write in.
What do you mean by less stress on the cardiomyocytes? That might be partly right. What happens? The hint here, what did I tell you earlier in terms of congestive heart failure and catecholamines? They go way up, right? Yeah. Why?
Roland, do you want to read the question?
Then I guess we can use digoxin to help. Not really. So yes, digoxin can work in which you're forcing.
Well, yeah, digoxin, by the way, there are 2 studies using digoxin. The reason why I didn't put it up there, it's not a standard form of therapy. In England, they don't use digoxin for congestive heart failure because of its toxicity.
Oh.
But it helps for patients with low ejection fraction. You can use digoxin very carefully, very carefully. The reason for that is that if you are not careful, it leads to rhythm disturbances and increase in mortality. But definitely it helps. The studies are RESTORE, where if you withdraw the digoxin on a patient who is doing well, they go back to congestive heart failure. So using digoxin helps. Adam, that's true. But my question, Adam, is on beta blocker. Tell me why. Well, we can use digoxin to help. That's correct, Adam. But my question to you is, why do we use, if you say that the contractility decreases, which is correct, why do you use it then in congestive heart failure? And you should use it because I told you 25 to 30% there is an improvement. But why?
Let's give him a couple minutes or a couple seconds to respond.
Tell him, Jabel Guzman, what's your answer?
You're less stress on the cardiomyocytes, which is true.
Well, like I told you, the catecholamines go up. Why? Because they're overstimulated, isn't it? When you use your beta blocker, so if you don't treat it with beta blockers, what happens? You really stimulate the sympathetic system. In the heart, 70% of beta receptors are in the heart, as high as 71%. So you really downregulate them to the point that they cannot be stimulated anymore. So what you do is to give beta blockers to replenish your beta-1 receptors so that they will be responsive again. That's the only reason for that. Yeah. That's the reason why. The other effect of a beta blocker, of course, is slowing down the heart rate, which is beneficial. And that's why if you cannot slow it down with the beta blockers, ivabrabine now, which is available for use, but they have to be in sinus rhythm because that's the only way it goes. Yeah. But don't forget that the beneficial effect of beta blockers is due to the fact that before you use the beta blockers, there is down regulation of the beta-1 receptors, which is 70% in the heart. Okay, so you give them a chance to be replenished again and would be responsive to sympathetic stimulation. That's the only reason it works. Okay?
Great.
So that is it for today. Thank you so much to all of you who joined us today. A huge thank you to Dr. Lou McCall for giving a wonderful breakdown cardiac pharmacology, especially for CHF management. So,
Well, back to the use of the use of ACE inhibitor result in 25 to 30% improvement, risk reduction. Okay, beta blockers as high as 30 to 35% risk reduction. Going back to the classic case for the use of ACE inhibitors would be the Consensus 1 study. There were only 253 patients, but they were all class 4. Guess how much reduction, relative risk reduction? In 6 months, it was reduced 40%. After 1 year, 30%. The others that I presented today, the SGLT2 inhibitors, it's amazing. We don't know how they work, but it's 30% risk reduction again. Okay. We don't have risk reduction for the myocyte inhibitor, but for the ibuprofen, it's just 8%. But I think this will be selective use for congestive heart failure. I want to repeat, the basic treatment now would be ACE inhibitors and ARB. They are going to be supplanted by ARNI, angiotensin receptor neprilysin, because compared to ACE inhibitor, they used an old ACE inhibitor. There is improvement by risk reduction by 20%. That's amazing. So keep that in mind. All right.
That was wonderful. Thank you so much for joining us today.
Okay.
For everybody who joined us at home or wherever you may be on social media, we really appreciate all of your comments.
The congestive heart failure, because it's such a big problem. There will be a lot of questions on that in your USMLE CK2, I'm sure. And don't forget, USMLE CK2 is going to be the only measure now, objective measure for the matching program, right?
So know CHF, know the pharmacology, know the pathophysiology, definitely know the pharmacology because we had Dr. Lumikow explain it to you. If you see any new MBME questions, maybe he wrote them. Definitely know them. So yeah, thank you so much.
Thank you again so much. We love to join you guys.
Okay.
We will be posting a new question next Thursday on all of our social media platforms, Facebook, Instagram, LinkedIn, and Twitter. So be sure to check those out, leave your comments, and then join us the following week as we kind of address the question as we did today, break it down, and answer any questions you may have.
Yeah, Townshend finally came up with a question there. It's the question, right?
Yeah.
But it should be specifically on better 1%. But she got the message.
She did well.
Yes.
Very
So
good.
thank you, everyone.
Thank you,
Have a good day.
everybody.
Take care.